Okay, you want me to
All
start,
right,
Jake?
good afternoon, everybody. We'll go ahead and get started. It is noon, and we have a lot to cover today. We are very lucky to have Dr. Jennifer Wyckoff here with us this afternoon. Dr. Wyckoff is a clinical professor of internal medicine in the Metabolism, Endocrinology, and Diabetes Clinic at the University of Michigan. Dr. Wyckoff serves as the Associate Clinical Chief for that MEN division here at the university. Her clinical interests are center on diabetes with specific emphasis on diabetes and pregnancy, type 1 diabetes and technology, patient education, and cystic fibrosis related diabetes. So with that, I'll pass it off to Dr. Wyckoff. Thanks so
Thank you.
much.
Yeah, it's my pleasure to be here today. I'm honored to get to speak for the MCT2D webinar today. I'm a huge fan of MCT2D. The work that's being done in the state of Michigan by this group is absolutely remarkable. I'm going to be talking today about gestational diabetes. I believe everyone can see my screen already. And I have no conflicts of interest. And our learning objectives are to be able to describe the scope and causes of GDM, talk about screening and diagnostic criteria for GDM, review the treatment targets and goals, discuss risks and treatment options, and describe postpartum care after GDM. So it's an ambitious set of learning objectives today. I do have a quick initial survey. It's not clear to me how many folks in our audience who are family practice provide obstetric care and how many medical folks on the internal medicine side actually provide medical management for gestational diabetes. So I wanted to take a quick survey and see who the audience was.
Are you able to see the survey on your end, Dr. Wyckoff?
I can see the survey.
Okay, great. I wasn't sure if you could or not. We'll let it run for a sec and then I'll end it. All right, looks like we have a good response rate. I'll go ahead and end the poll. The results should be sharing.
All right, so actually quite a few people who provide obstetric care. All right, that's great. And about half and half with medical management of gestational diabetes. Thank you. Um, okay, so to get started, we're going to work with a case. This is a 37-year-old, Gravida 2, Para 1, 26 weeks, history of Hashimoto's, really no other significant past medical history, has a new diagnosis of GDM. I built this case as if you are the primary care doctor and not providing obstetric care. So I wanted to make it applicable to everybody. Uh, she had a completely normal delivery, no complications of any kind, 5 years ago with her previous pregnancy, no gestational diabetes, some family history of type 2, but not a lot. She has two sisters who never had GDM. One has celiac disease. She's pretty sedentary, and her only medications are a prenatal vitamin and levothyroxine. 6 months ago, she had an A1C of 5.5%, normal liver function tests, but her midwife is concerned that she has gestational diabetes and wants to refer her to a maternal fetal medicine specialist. And she wants to discuss it with you first because she's really struggling to believe that she has gestational diabetes. Now, prior to her last pregnancy, she weighed 160 pounds, BMI of 26. She gained a lot of weight with that pregnancy and did not lose it all. So prior to this pregnancy, she was 190 pounds and now she's 220. So she's actually gained a fair amount of weight with this pregnancy as well. And her BMI prior to the pregnancy was just over 30. And if you look, she had a 75-gram IAD-PSG criteria, one-step oral glucose tolerance test, and all of the values were significantly elevated. So what can you tell her about this? She's saying, I never had GDM, my sister's never had GDM. She's feeling really confused by this diagnosis. Look at the following questions and select all that apply, because it's more than one of the above, so select all that apply. Sorry. I've cheated. I've given you one answer already. I didn't mean to click already. How's the poll going, Jake?
Good. We have 19 responses so far, and we have 31 folks here, so not
Okay.
too bad. Looks like it's leveled off, so I'll go ahead and end it.
All right. So, yeah, so it's correct that gestational diabetes complicates roughly 10% of pregnancies in the US. The other parts here that are correct is that that has actually tripled, more than tripled in the last 30 years, because it was roughly around 3% 30 years ago. And it's also true that she has a lot of risk factors, traditional risk factors for gestational diabetes, which I think we're pretty much all aware of. It looks like everybody got those right, so good job. Okay, so this is actually one of my favorite studies out there right now. This is actually looking at 25 million pregnancies that were recorded. It's about 60% of the US population of pregnancies between 2016 and 2022 that were captured in the nationwide readmissions database, which is an AHRQ database. And it shows very clearly the increase of gestational diabetes from 3% to 8 to 9% in 2022. This is an actually fabulous study looking at severe maternal morbidity. And we already covered clearly what the risk factors for GDM are, and she has a number. Obesity, she's had rapid maternal weight gain, she had an A1C of 5.5, so she wasn't really pre-diabetes, but she was very close, some family history of type 2, sedentary lifestyle. So going back to the case, she's done some reading, and she's concerned that the new one-step OGTT that was used this time, which wasn't what was used in the last pregnancy, is the reason that she now has GDM. She read that more GDM is diagnosed with the new diagnostic criteria, and she's asking if that's why she was diagnosed with gestational diabetes. And what can you tell her?
All right, ending poll and sharing results.
All right. So, first thing, the use of IAD-PSG criteria does increase the rate of gestational diabetes diagnosis. So that is actually a true statement. But she would have met criteria regardless of which criteria were used. She has very high glucoses at 3 different time points. Now, IAD-PSG criteria are based on the prediction of neonatal outcomes, whereas older criteria were based on maternal risk for developing type 2. Looks like a lot of people got that. Good job. And there's actually a recent meta-analysis looking at whether IAD-PSG criteria were better or not than Carpenter-Kustan at predicting LGA and macrosomia, and it really wasn't very clear. I'll show that meta-analysis in just a second. So just to remind everybody about the difference between the criteria, the Carpenter-Kustan criteria, which was widely used before IAD-PSG and still is widely used, was based on a 100-gram oral glucose tolerance test, and you had to have 2 abnormal values to be considered gestational diabetes. The IAD-PSG criteria is based on 75 grams, and you only have to have 1 abnormal value. And so the main reason why IAD-PSG diagnoses more patients with GDM than Carpenter-Kustan is the fact that it's only 1 abnormal value. And if you look, the difference between the actual numbers is not very much. Remember that with the IAD-PSG, you're actually getting less of a glucose load. And the real thing that makes a big difference in the diagnostic rates is the fasting glucose, because if you have a fasting glucose and that's your only abnormal value, it would not mean that you have an elevated fasting glucose and that's your only abnormal value under Carpenter-Kustan. That would mean that you did not have gestational diabetes, but it would mean you did under IAD-PSG, and that's the main thing that drives the difference in diagnostic rates. If anybody wants to go look at the data that IAD-PSG is based on, it's based on the HAPO study, the references here, and the HAPO study was a very dense study. There are multiple publications from it. It was based on 25,000 women, 15 centers, 9 countries, a lot of data there to digest. And this is the meta-analysis I mentioned that showed perhaps the one step is better, but it didn't reach statistical significance. So it really isn't clear which one is better for predicting LGA. So your patient still can't believe she has GDM. She wants to know why. What can you tell her? Okay, so insulin resistance, whoops, sorry, try that again. Insulin resistance increases steadily beginning around 20 weeks gestation. In normal pregnancy, the pancreas increases insulin production to compensate for increased insulin demand. But in pregnancies complicated by GDM, the pancreas is unable to increase insulin production to meet increased demand. So a lot of women will say, oh, the pregnancy is causing my blood sugars to be high, but pregnancy increases insulin resistance for all people who are pregnant, and it's really the pancreas's inability to meet that demand that is the problem. And I think that's important to tell patients so that they realize that the next time there is a challenge to their pancreas's ability to make insulin, whether that's because they've been given steroids or they are pregnant again, or they're on some other medication that really increases insulin resistance, that they are very likely to develop hyperglycemia again. And I think that point is very important because many women get the message with gestational diabetes that it's going to go away after the pregnancy. And while it's true that the majority of patients do not have type 2 diabetes immediately after pregnancy, it doesn't mean that their pancreas functions normally when presented with a challenge. So it's important for women to be aware of their high risk and that risk isn't just pregnancy related. So this is a very common a visualization of insulin requirements during pregnancy. And you can see that in the first trimester, insulin requirements are very similar to slightly lower than they are in non-pregnant state. But starting around 20 weeks, there's a really dramatic increase in insulin requirements. You can see this in your patients with pre-existing diabetes who are already on insulin. They suddenly require a lot more insulin. And this is what causes the hyperglycemia that you see in gestational diabetes. And the reason that we're testing around that 24 week mark is because we are looking to see where they are at that point. For their diagnosis of gestational diabetes. But you can see that the insulin resistance increases until about 36, 37 weeks. And then it dramatically falls off at delivery. And that's actually a time period when women often have hypoglycemia if their insulin has not been reduced or discontinued. There are lots of reasons, and it's not just one reason that insulin resistance increases. The thing that I actually always think of is that pregnant women often look a little cushingoid, and that's partly because of the placenta 11 beta hydroxysteroid dehydrogenase type 1 overactivity elevating cortisol levels. So I just always think of women having sort of almost mild Cushing's when they're pregnant, but there are lots of reasons to actually increase insulin resistance. But the insulin deficiency is also complicated. There are some changes that happen naturally during pregnancy that actually reduce insulin secretion slightly, but the vast majority of the reason people have insulin deficiency is from genetic predisposition to type 2. So going back to the case, she's now convinced she has GDM, but she wants to know what's wrong with her pancreas. Why me? And so are there any things that you would want to consider other than type 2 in this patient? All right, so about half of people want to screen for antibodies for type 1. A few are wanting to screen for MODY. All right. So I would agree to screen for antibodies for type 1. Screening for MODY is something that's been written a lot about in gestational diabetes. The reason I'm not suspicious in her case is she did not have gestational diabetes in her first pregnancy. If she'd had it in her first pregnancy, I'd be more interested in screening for MODY. The reason I'm interested in screening for her is because she has a personal history of autoimmunity with her levothyroxine use for Hashimoto's, and she has a sister with celiac. So that kind of makes me a little bit concerned for type 1. Not very, it's still unlikely, but it's worth sending antibodies off for. So remember, there are a lot of things that cause diabetes, and I've picked up some unusual cases of diabetes in my patients with gestational diabetes. Probably the most unusual one ever was a patient with Bardet-Biedl. And you don't usually think about Bardet-Biedl and pregnancy in the same sentence, but she had a variant of Bardet-Biedl. So it's worthwhile just taking a moment to think, what is the cause of this person's diabetes? Mostly so that you don't miss evolving type 1, which can be catastrophic during pregnancy. And the other thing to think about a little bit is also, does this person have a history of any pancreatic disease? Is this the type 3CD diabetes that's starting? MODY, we talked about, has been written about quite a bit. It causes about 1 to 2% of gestational diabetes is MODY, mostly glucokinase deficiency and some HNF1 alpha. I will screen for this in someone who does not look like a typical patient with gestational diabetes who is having GDM. The key there is often that their fasting glucose is really quite elevated compared to their postprandials. And about 3 to 12% of patients will actually screen positive for antibodies for type 1. The more antibodies they have, the more likely they are to progress. So in this study, looking at women with gestational diabetes, the rate of progression to type 1 was actually quite common if people had 3 positive antibodies. And obviously, the fewer antibodies, the less likely people went ahead and converted to type 1. So which of the following is true? Because you've screened her now, her antibodies are negative, she has gestational diabetes, and she wants to know, why does it need to be treated? Like, why do I need to treat this? And so what are you going to tell her about treatment? So you're correct. It's all of the above. Um, so gestational diabetes increases the risk of obesity, type 2 diabetes, and hypertension in offspring. It also increases the risk for severe maternal morbidity. I had put up a slide earlier that showed the little bit of data around that. Severe maternal morbidity includes lots of terrible things. It's a composite outcome, which includes heart failure, heart attack, amniotic fluid embolism, etc. And so GDM is actually a risk factor for very severe maternal outcomes. Treatment of GDM actually reduces the risk for preeclampsia and reduces the risk of obesity in offspring. So this is more data on the severe maternal morbidity. You can see the definition over there on the right. And this was going back to that AHRQ slide I put up earlier. This is the 25 million pregnancies. Of that 25 million pregnancies, almost 500,000 women had one or more of the severe maternal morbidity indicators. So it's actually quite common. And you can see that gestational diabetes really had an increased odds ratio. Not nearly as much as pre-gestational diabetes or chronic hypertension. Chronic hypertension is absolutely terrifying if you look at the odds ratio associated with it. But gestational diabetes was absolutely a significant contributor to severe maternal morbidity in this study. And remember that gestational diabetes is a major risk factor for hypertensive disorders of pregnancy, so blood pressure should be watched very carefully. I encourage all of my patients to have a blood pressure cuff and monitor their blood pressure in the third trimester. And this is actually very recently presented data showing that in individuals who achieve either rapidly improving to optimal gestational diabetes control during their gestational weeks after their diagnosis of GDM. So if somebody gets themselves in really good shape within the first 8 weeks after their diagnosis of GDM, that their offspring have a much lower rate of obesity. This is actually retrospective data, but that's actually very, very convincing to a lot of women that this helps protect children in the long term. And they followed these offspring up until age 10 in this study. So if you were at my last talk on diabetes and pregnancy, I talked a bit about targets and goals. These are the classic targets: fasting of glucose less than 95, a 1 hour postprandial glucose less than 140, and a 2 hour postprandial glucose less than 120. And these are what you really want to be focusing on for your patients with GDM. This has not changed in a million years. Goals, if you're following an A1C, the A1C should be less than 6 during pregnancy. And if you're using a CGM, the pregnancy-specific time and range, 63 to 140 milligrams per deciliter, should be greater than 90% for gestational diabetes and type 2 diabetes. But remember that the CGM target range is not the target, it's the goal. You really want to be focusing on making sure that these fastings are achieved. So someone can be 100% time in range and not have achieved the fasting target of less than 95, and that will really increase the risk for large for gestational age and macrosomia. So you want to focus on achieving the fasting glucoses as well as the postprandial glucoses, and you should be using the CGM as a tool to help you get there, but not the percent time in range as the ultimate target. The targets are less than 95 fasting and under 120 at the 2 hour. That was actually highlighted when this was originally published in 2019, the guidelines on CGM time and range, because it was clear back then that these were not optimal goals. The rate of LGA was still quite high for patients who did achieve the target range of 63 to 140. And there have been multiple different studies since then looking at the contribution of overnight hyperglycemia to that, which is considered significant. Now, does CGM help in gestational diabetes? So this is really quite a sea change for me. For decades, I've been following finger sticks in gestational diabetes. And now there's much better CGM coverage in gestational diabetes, and women really actually like CGMs. They're much more convenient than sticking your fingers. And so there was recently a meta-analysis, which I've got up here, that shows that CGM use in gestational diabetes was associated with lower A1Cs, less gestational weight gain, and lower birth weight, so less LGA. So that was actually pretty significant. And you'll see that there's a lot better CGM coverage in GDM. Oh, we talked about that. So here's a couple of tables of insurers here in Michigan and who covers CGM and when. You'll see that for most insurers, if you're not on insulin, they are not covering. But once you are on insulin, then many of them are covering. So this is worth looking through. It also shows whether it's a pharmacy or a DME benefit. I have to give credit to this slide to the incomparable Heidi Dietz, who's one of our fearless leaders in MCT2D, because she is the queen of being able to figure out insurance coverage. All right, so now your patient asks the question that every patient with GDM asks: what should I eat? What would you tell her?
Dr. Wyckoff, can you see this poll? It was not launching for me.
I can see it.
Okay, good.
I see it. I assume everyone else does.
Good, good. It just spun for a minute. Just wanted to make sure.
I make everybody work hard today on their lunch hour. I'm sorry. All right. So I love it. Everybody's referring people to dietitians. That's perfect. That is always the right answer. I think referring someone to a dietitian is never the wrong answer. So what you would tell her is she shouldn't, whoops, sorry. What you should tell her is she should not gain more than half a pound a week for the remainder of the pregnancy. She's already obese, and so to be in the IOM guidelines for weight gain, she needs to not be gaining a lot more weight. But she should not be losing weight, and we'll touch base on that. The American Diabetes Association recommends 175 grams of carbohydrates and 70 grams of protein daily. And carbohydrate intake less than 100 grams daily increases the risk of neural tube defects. So you don't want someone on a keto diet, and you're referring her to a dietitian. I recommend the referral to a dietitian, both because there's data supporting better outcomes if you have a dietitian involved in taking care of gestational diabetes, but because every person's nutritional requirements are different. So to say that anybody needs X amount of carbohydrates and that X being always true, it's not going to be. The nutritional needs of someone who is 100 pounds and has multiple food allergies and food issues is going to be completely different than someone who's 300 pounds. They require different amounts of total calories, different amounts of total carbs, and each person really needs some individualized help when it comes to working their way through gestational diabetes. So these are the Institute of Medicine guidelines. And as you can see, she qualified as obese, so her total weight gain for pregnancy should have been between 11 and 20 pounds, and she's already gained more than 20 pounds during the pregnancy. So you really aren't trying to have her lose any weight, but you're trying to, not have her gain more than half a pound a week for the rest of her pregnancy. And so this is an older study. This is by Pat Catalano. And he's done a lot of work in the gestational diabetes pregnancy world. He's a MFM. And in this study, he showed that in overweight and obese women, weight loss or gain less than 5 kilograms, weight gain less than 5 kilograms, is associated with an increased risk for SGA, decreased neonatal fat mass, lean mass, and head circumference. And so this is really why we shy away from allowing people to lose weight during pregnancy. We're concerned about an increased risk for SGA primarily. And this is the reference for the ADA guidelines and the dietary reference intakes as well. And the truth is there's actually very poor data on nutrition in gestational diabetes. There are very few randomized controlled trials. They tend to be small. And so we really don't have a clear, clear guidance on what the best thing for widespread recommendation for nutrition is. And that's another reason why I really recommend dietitian referrals, because I feel that a dietitian can work with a patient, figure out how much they're eating, what their caloric intake is, and move them towards a healthier diet. And it's going to be different for every person. So there is no one size fits all, honestly, for this. All right, so GDM. Okay, she has tested for a week, and these are the numbers she brings you. So her fastings have been between 92 and 105. Her 2-hour post breakfasts have been between 119 and 142. Her 2-hour post lunches have been generally in the 120s. There was one that was like 84, and her 2-hour post dinners have been generally okay, but there was one that was 145. And what I'm urging folks to do for this situation is actually ask a lot of questions. What do you eat? When do you eat? What do you drink? Does it have caffeine in it? How much are you exercising? When? Are you sleeping? Are you stressed? What times are you checking these? Are you having pain? Are you having illness? What are you doing? Because you find out a lot of things when you actually ask all these questions, and sometimes it makes a big difference in your treatment plan. So going back to this slide, I would have looked at this and said, okay, you've got definitely two fastings that are elevated. I might need to start an overnight, but like almost all of your, post breakfast and post lunches are elevated. I should be starting short acting at breakfast and lunch. But when you ask all these questions, you find out some things. You find out that that's Tuesday, Wednesday, Thursday, Friday, and Saturday. And on Tuesday, Wednesday, Thursday, and Friday, her blood sugars are generally in the 90s. Not all quite in range, but most of them. And Saturday, when she sleeps in really late, her blood sugar is higher. And that's part of a little bit of a dawn phenomena there. You often see that the blood sugars are higher if people are sleeping in later. And so that kind of changes how you think about that number a little bit. Her 2-hour post-breakfast during the week, she has been drinking coffee and probably eating like a breakfast sandwich in the car on her way to work. And so she's arriving from sitting in the car for 45 minutes and eating her breakfast and then checking her blood sugar when she arrives at work, and she's high. But on Saturdays, when she gets up, eats a bowl of cereal, and then runs around in circles, doing her chores, her blood sugar is fine at her 2-hour postprandial. She has a sedentary job, so 2 hours post-lunch, she's sitting at her computer working, and her blood sugars are high. But again, on Saturday, when she's doing yard work, her blood sugars are fine. And 2 hours post-dinner, she's usually okay because she listened when you first met her, and she's taking a wonderful walk after dinner every night. But then on Saturday, that was when she went out and ate popcorn at the movies and didn't go for a walk, and her sugars are higher. So here, you're advising her about lifestyle changes. You're telling her, okay, let's change up that breakfast a little bit, and let's get you walking a little bit further when you get out of the car. Let's see if you can go for a walk after lunch, and just don't eat popcorn at the movies. So here, she actually makes those changes, and now you see something completely different. She's got her post meals pretty much in line, and the problem just is that mild hyperglycemia fasting in the morning. And so now you're thinking, okay, I do need to give her maybe a little bit of something at bedtime, but I'm not having to give her right now anything at meals. Every week she's pregnant, she may become more insulin resistant, and this may change. But for this week, week 2, the conversation's really going to be about, do I need to change something with those fastings? So since the dawn of time, or at least a long time, the sweet success algorithm, which is the California diabetes and pregnancy algorithm, has been used. This is actually quite out of date at this point, but this is still what a lot of people kind of use as a beginning place for treating gestational diabetes. But you'll see that the actual algorithm itself mentions Levemir, which isn't on the market anymore, and NPH, and doesn't include Lantus, and it uses 1 hour post breakfasts. Just a side note on 1 versus 2 hour postprandials. So 1 hour postprandials have been actually shown to be superior in gestational diabetes to 2 hour postprandials. But many groups, including mine, just use 2 hour postprandials for all of our pregnant patients with any kind of diabetes because it's confusing to try to switch back and forth between 1 hour and 2 hour. And the reason we chose 2 hour instead of 1 hour is that for our patients with pre-existing diabetes, especially type 1, if you're trying to get people to target with a 1 hour postprandial, you often find that they're having lows at 3 hours. But the California Diabetes and Pregnancy Sweet Success Program was really set up for gestational diabetes, and that is why it used and uses a 1 hour postprandial glucose. And this gives you step-by-step instructions on how to start insulin for gestational diabetes. And it gives you kind of a range of where to start your bedtime insulin dose between 8 and 20 units. And I think that's a pretty good call. Obviously, I personally kind of factor in a person's weight. I'm going to start with a much lower dose if you have a smaller person, a higher dose for somebody who's larger. If you were in my last talk on diabetes and pregnancy, we talked about metformin and why we don't use it in addition to insulin in patients with type 2 diabetes. I won't go through all of those slides, but just to recap, metformin does decrease large for gestational age babies. There's really good data for that. But there's also an increase in small for gestational age babies, so it's not really clear whether that's a benefit. It's causing some intrauterine growth retardation because just like in adults who are exposed to metformin, we tend to lose a little bit of weight, so does the baby. And that intrauterine growth retardation increases the offspring's risk for obesity in the future. But the more recent data, animal data in rhesus monkeys, shows that there's renal dysmorphology with exposure to metformin. And so there's a lot more work that needs to be done to look at the safety of metformin in pregnancy. So the American Diabetes Association currently recommends that metformin be discontinued before the end of the first trimester in any patient who's pregnant and not used as a treatment for gestational diabetes. And that's also true for ACOG guidelines. ACOG is not recommending it as first-line treatment for gestational diabetes. So metformin is really not it should only be used as a last resort in gestational diabetes. And now I want to talk for just a couple minutes about postpartum care, because this is something we all struggle with. It's really, really hard to get people to come in for postpartum medical care. It's also hard just logistically to time it. Like, when do people deliver? We never quite know. And I would urge everybody to really, really think about their postpartum care for their patients with gestational diabetes and really make it intentional. Have those appointments like on the books as soon as you know someone is pregnant. The postpartum oral glucose tolerance test is something that is very hard to get. Nationally, the numbers of people actually completing them are quite low. One thing that our hospital has put in place is actually a 2-day postpartum, just prior to discharge, oral glucose tolerance test. That's actually improved our uptake of oral glucose tolerance tests and moved us out of the single digits into the double digits, which is a major improvement. We've more than doubled our rate of getting oral glucose tolerance tests done. So if you aren't doing that within your hospital systems, if this is something you have any control over, you might want to look at Erica Werder's data and the other data that's available for postpartum oral glucose tolerance tests at 2 days. It definitely increases the capture rate. And then be aware of postpartum hypertension. Many people, when they're thinking about gestational diabetes, don't recognize the risk of postpartum hypertension that's involved. And many women will develop de novo hypertension postpartum. So following up blood pressures in our gestational diabetes population postpartum is very important. Supporting breastfeeding is very important. Women with diabetes and gestational diabetes have lower rates of breastfeeding, in part because of medications and concerns around medications in the postpartum period. Remember that postpartum care is preconception care, so discuss pregnancy intent and contraception. And then realize treatment for diabetes, prediabetes, obesity, PCOS are all things that these patients often need, and to reduce long-term risks. We do know that more frequent postpartum care in high-risk patients, like women with gestational diabetes, decreases hospitalization rates. And we also know that only about half of women who have a pregnancy complicated by diabetes actually reestablish care with primary care within the first year postpartum. That's why I'm saying you need to set up those appointments while they're pregnant so that they know when they're coming back, and you need to stress the importance of the return visit, which is always a challenge. These women have new babies and they're very busy, but trying to get them back in is very, very important. And remember that preconception care for patients who have diabetes, some of these women will have diabetes, preconception care reduces congenital malformations from 7.2% to 2% in women with pre-existing diabetes. So you want to make sure that these women know if they have diabetes postpartum and that they're screening for it moving forward. And we all know that a history of GDM is a risk factor for all kinds of things. And it's not just hypertension and diabetes, but also obesity-related cancers, psoriasis, sleep apnea, hypertension, kidney stones, high cholesterol. So there are a lot of things that should be paid attention to in your patient who has a history of gestational diabetes. So I know we're all overwhelmed by the number of patients out there who are on GLP-1s, both patients who have obesity and patients with type 2 diabetes. And we're seeing more and more patients who are becoming pregnant on GLP-1s. I'm actually seeing a patient today who became pregnant on a GLP-1. So GLP-1s are large molecules, and they generally do not cross the placenta, or at least we don't think they cross the placenta. There are receptors for GLP-1s on the placenta, and how that impacts fetal growth and fetal health are still things that we need to know more about. But specifically in relationship to breastfeeding, semaglutide, oral and injectable, has actually not been detected in breast milk. Remember, big molecule, it probably doesn't get into breast milk. I want to say that the size of this study that I'm referencing here is only 8 patients. So it's not a lot of people. But there's been no data on the impact of breast milk nutrients for women who are on GLP-1s, so we actually don't know if it is detrimental to the quality of the breast milk. It's not approved in breastfeeding, so I would not really recommend using any GLP-1 in breastfeeding. You definitely cannot use oral semaglutide. There is a component of the pill called salcaprosate sodium. Don't even know what that is, but that component is present in breast milk and is considered hazardous. So you should absolutely not use oral semaglutide for breastfeeding. And there's a newly approved GLP-1 that you've probably all heard about, orforglipron, and that is actually a small molecule. It may cross the placenta. We don't know. And it may be present in breast milk. It probably is. Again, we don't know. There's no data. In the ATTAIN 1 and 2 studies, which are the studies that were used to get FDA approval for orforglipron, there were 14 women who became pregnant while on the drug, but we have no data on them at this point. So I do not have any data on this, and I just want people to be aware that it's biochemically very different than the other GLP-1s. So it's going to need to be managed completely differently in pregnancy than the others. Okay, back to our case. So our patient has now delivered. She has had a baby. Everything went well. Things are good. And she now is a year postpartum. And you have been following her, and she is doing well. And now she calls you to report a positive pregnancy test. You have been following her A1Cs. She has not had prediabetes or diabetes um, uh, when you have followed her, but your last check was 6 months ago and now she's pregnant. What do you do?
And Dr. Wyckoff, there are a couple of questions in the chat, just so you know, we can answer
I'm
those
gonna
at the end.
I'm gonna get them at the end. I see them. They're good
Yep,
questions.
great.
I've got the chat open. I'm watching.
A couple more seconds.
Okay. So check A1C and fasting glucose, and if normal, get oral glucose tolerance test now. That's not necessarily the wrong answer because that's very much being very careful. The answer that I, whoops, sorry, the answer that I like is check A1C and fasting glucose, and if normal, get oral glucose tolerance at 24 weeks. Checking the A1C and the fasting glucose is a very good first trimester screen. It is not wrong to get an oral glucose tolerance test in the first trimester, but I prefer the A1C and fasting glucose. And then if they're normal, getting the oral glucose tolerance test at 24 weeks. If you get an oral glucose tolerance test and it's normal in the first trimester, you absolutely have to repeat it at 24 weeks. And I would not wait to check an oral glucose tolerance test at 24 weeks because your patient has a history of GDM and she may be running higher glucoses already. And there is data for this in the Toboggan study. So this is a study out of Australia that looked at 802 women that were randomized into immediate treatment and delayed treatment for gestational diabetes diagnosed in the first trimester. And it actually, this is a poor slide, my apologies, but it shows that there was a significant difference in the adverse neonatal outcomes. There was a reduction in adverse neonatal outcomes for the group that got treated in the first trimester. A lot of that actually had to do with a difference, a statistical difference in the rate of NICU admissions and respiratory distress in the fetus, in the neonate, which was surprising to some, but actually increased respiratory distress is a commonly recognized complication of pre-existing diabetes, and not something we usually think about in the gestational diabetes world as much, but actually is actually a known complication. And that was one of the big drivers in Toboggan for reducing its overall adverse neonatal outcome, composite outcome. So in summary, and I can't believe it, I'm actually going to finish on time. Gestational diabetes complicates about 10% of pregnancies in the US, so it's really quite common, much more common than it was 20 or 30 years ago. When you are treating it, don't replace your GDM targets, those traditional fasting and postprandial targets, with a CGM time and range, because you will be under-treating your fastings, and the fastings are very important in predicting large for gestational age and macrosomia. But do use CGM if your patients would like to use a CGM if you can get coverage, because there does seem to be benefits from using CGM. You need a dietitian. Dietitians are wonderful. They can really help coach your patient and improve things like less maternal weight gain and improve nutritional value. Do avoid metformin. I will answer those questions in just a minute. Be very intentional about postpartum care. These patients really need that postpartum follow-up, and screen in the first trimester. All right. And I have a million references at the end of this if you want to read everything that was ever known about diabetes and pregnancy, because I took out some slides because I thought I was going to be too long, but I left the references in, so there's plenty of references there for everyone to look at. And I want to thank everybody for their time. And I will answer the questions in the chat now. What about metformin use in PCOS infertility to aid in getting pregnant? Any research on this practice related to renal issues, SGA? All right, so metformin has for a long time been used by fertility folks to help improve ovulation rates in women with PCOS. And there's very good data that improves ovulation rates. Now, the reason why the ADA says stop by the end of the first trimester is it recognizes that many women will become pregnant on metformin, and it wants to make sure that it's stopped by the end of the first trimester. So is there any data specifically about metformin exposure in the first trimester and renal issues in SGA? And the answer is not anything about renal issues. Nobody ever had renal issues like on their radar until that rhesus monkey study came out 2 years ago. And so right now I believe a number of groups are trying to get data, either retrospective data or follow up some of the larger studies like the MIG-TOFU study in New Zealand and Australia, or Denise Faig's MIGHTY study, or the MomPod study, looking for outcomes and renal outcomes. And right now there's just nothing out there. So we really don't know about renal issues. However, people who know a bit more about metformin in the placenta than I do, another reason why they're saying to stop by the end of the first trimester is that they don't feel like there's a lot of metformin transfer in the first trimester. And so it may be safer in the first trimester than it is in the second and third trimester. I am not a placental expert, but this is what people seem to think. Rhesus monkey placentas are apparently very similar to human placentas, but again, they are slightly different, but not much different. Rat and mice placentas are completely different, so that's a whole different story when you're looking at that. In my world, if I have a patient who's having a really hard time, she has PCOS, she's really trying to get pregnant, I will let her continue metformin until she's pregnant, and then I will stop it and transfer her over to insulin if needed as soon as she's pregnant. So I think it's, in my practice, I'm still using metformin until someone is pregnant, and then I'm stopping it. I hope I answered that question. In regard to oral glucose tolerance test, if breastfeeding, what test is recommended instead, if any? In regard to oral glucose tolerance test, if breastfeeding, what test is recommended instead, if any? You can do an oral glucose tolerance test at 2 days postpartum or at 4 to 12 weeks postpartum if people are breastfeeding. The breastfeeding does not have a huge does not make a huge difference on oral glucose tolerance test results. So it's not a contraindication to doing an OGTT if someone's breastfeeding. If that was the question, I may not have got the question right. Can you use CGM specific doses, or must patients still do finger pokes? Okay, that's a great question. So what I tell people is that I want them to use their CGM, and I want them to mark in their CGM when their breakfast, lunch, and dinner is. So what's fasting, what's 2 hour post-breakfast, 2 hour post-lunch, and 2 hour post-dinner. Because if I just look at a CGM and I don't know when people have eaten, then I'm really not getting a picture of what's going on. I need to have those very specific time points to be able to identify if people are hitting their targets. But I don't make them do finger pokes all the time. So the place where I really care about the finger pokes is on the fastings, because if you're trying to compare a finger stick to a CGM glucose, the CGM is always going to lag behind the finger stick. So if you're trying to compare finger sticks to CGM levels in the postprandial state, they're going to have a fair amount of difference because there's that lag. I always like to see the fasting, because the fasting is going to be presumably not changing. It's going to be a stable glucose, and that's where you're going to see that your CGM should be pretty close to your finger stick. So I think of the fasting as the place where I can double check that the CGM is accurate. So I do ask people to get me fasting glucoses as a finger stick, at least some of the time, but I'm not having them do 4 finger sticks a day because that would probably drive people crazy. They're on a CGM, they don't want to be doing that many finger sticks. I tell them to do a finger stick if they don't believe the number, if they're having symptoms and they feel like they're low and they're on insulin, and then I ask them to do some fastings to make sure that there's pretty good correlation between the CGM and the finger stick, but I don't have them do 4 sticks a day. Will the 75-gram load harm the milk coming in or affect breastfeeding baby later in the in the postpartum period? No, it won't. I mean, it's like they just like if you rounded up a bunch of women who were breastfeeding and asked them if they had a Coke or a mocha frappuccino from Starbucks or some other sugar or huge glass of orange juice, they will have people will have things like that while they're breastfeeding, and it's not a concern. Like they shouldn't be doing it every day, but doing a oral glucose tolerance test isn't going to hurt the breastfeeding baby. No. Um, all right. Okay. All right. Oh wait, there's one more. Okay, no. Are there any other questions? All right. Well, I hope I gave you 5 minutes to get back to your work and get your lunch done. And thank you so much for listening to me. I hope you guys enjoyed it. All right.
Thanks so much, Dr. Wyckoff. This was
Take
wonderful.
care. Bye bye.
Thanks, everybody. Have a great weekend. CME slides are up here. Um, and you can always access your CME through the Beaumont portal as per usual.
Thank you. All right, Jake, do you need me for anything else?
Nope, you are good, Dr. Wyckoff. Thank you
All
so
right.
much.
Thank you for all your help, Jake. Thanks, everybody.
Absolutely.
Bye.